Hello, good afternoon, everyone. This is Francesco Montorsi from Milano. I am delighted to welcome you all to the Urowebinar organized by the European School of Urology and the European Association of Urology. And together with Professor Marcus Graefen from the Martini Clinic and Hamburg University in Hamburg, Germany, we are happy to discuss for you the prostate cancer update courses 2019-2020. The schedule of the webinar is a little different than as usual if we did it at the real Congress place. We divided the presentation into two parts. I will be giving the first part of the presentation that will discuss the role of multi-parametric MRI, active surveillance, recurrence after curative intent therapies, and metastatic hormone-sensitive prostate cancer. And after myself, Marcus is going to discuss for you prostate cancer screening, staging, radical prostatectomy, and external beam radiotherapy, and castration-resistant disease. Prior to start off the presentations, I would like to remind you all to send in questions with the question tool that you can use on your computer. Please do remember that you have to fill the questionnaire at the end of the presentations in order to receive your CME credits. This being said, the first topic of my talk regards multi-parametric MRI. Where are we today? This is a classic slide taken from the very latest edition of the EAU guidelines. What is recommended today is that in biopsy-naive patients, we should always perform a multi-parametric MRI before a biopsy, and by using the PIRATES system, if the MRI is positive, we should combine both targeted and systematic biopsies. In the patients who have received already a negative biopsy in the past, it is again mandatory to use a multi-parametric MRI before repeating the biopsy. If the MRI is positive, we can use targeted biopsies only. So these are two important messages. If we place the research that was available in 2019 and 2020 in context, we now know that MRI targeted biopsy result in a higher rate of detection of high-grade cancers than systematic biopsy. And the biopsies guided by MRI should be used in place of the systematic biopsy or in conjunction with it. So this is the core area of research. And I have selected this paper from the New England Journal of Medicine coming from the NCI, which is carrying to us a number of important messages. The favorite machine that should be used is the 3 Tesla MRI, and if possible with an endorectal coil. Having experts genitourinary radiologists is important, and in this study, a large number of patients received both MRI targeted plus systematic biopsies in that same institution. We are talking about almost 3,000 patients. When using this technique, 62.4% of the patients were diagnosed having cancer. This is very high, suggesting that the combination of the targeted plus systematic biopsy when using a good technique is giving you a very large number of diagnoses. And this was different when looking at the same percentage of diagnosis of prostate cancer when using only systematic biopsy or only MRI, more or less 10% more. Clearly, as we would expect, the use of MRI targeted biopsy led to more diagnosis of cancers in the groups 3, 4, and 5 as compared to systematic biopsies. There was the addition of MRI targeted biopsy to systematic biopsies led to 10% more diagnosis, and of these, a third were clinically significant. Of interest from this study quite a large number of these patients were then treated by radical prostatectomy. And clearly we know that a number of our patients, they do show an upgrade in terms of Gleason score from the biopsies to the radical prostatectomy specimens. By using the combination of MRI targeted plus systematic biopsies, only 14% of patients showed an upgrade, which is clearly important because it is telling us that by following this way, we are able to identify the patients as precisely as possible. So the take-home messages is that if you use a combination of MRI targeted biopsy and systematic biopsy, there is a net decrease in the number of clinically insignificant cancers. If you do not use the systematic biopsy in conjunction with the MRI, you are missing almost 10% of significant cancers. And by doing so, the number of upgrades at the time of radical prostatectomy is significantly reduced. I would like to add one personal consideration from a surgical perspective. If you plan to do a radical prostatectomy on a patient, it is important to know the exact position of all cancer foci if you want to plan an hair-sparing procedure. This is one further reason, and we did publish this in a letter to the editor, to add the systematic biopsies to the targeted biopsies. The second topic I would like to cover is the active surveillance. This is an excellent to read article from Johns Hopkins, just published, where they did look at almost 2,000 patients treated with active surveillance, showing that if you use very rigorous criteria, the risk of mortality due to prostate cancer or metastasis is extremely low, as you can see here. And the reclassification at biopsy was 21%, 30%, and 32% at the 5, 10, and 15-year follow-up. If you put this into context, then we know, looking at the pathology of radical prostatectomy specimens in men who were ideally candidates for surveillance, we know that 25% of these cancers will be found anteriorly, and probably this is the reason why they were not found to start with. An interesting study from Canada is the ASIS study, which did look at the effectiveness of MRI-targeted biopsies versus systematic biopsies at the confirmatory biopsy. And we do have results now at the confirmatory biopsy done 1 year after the start of the study and 2 years after the start of the study. So the very last paper, which I selected, is looking at the long-term follow-up, but let's start from the beginning. 1 year after starting of active surveillance, there was no difference in the number of reclassification of cancer when comparing those who were studied with systematic biopsy compared to those who were studied with the MRI. But then, when looking at the 2-year follow-up down the line, there was a significant difference between the systematic biopsy and the MRI arm, suggesting that if you use the MRI from the beginning, you are selecting in a better way your patient population. You are able to identify a larger number of people with clinically significant cancer, and this is reducing the risk of the so-called reclassification after down the line during the study. And this is reflected also that of those who progressed to higher grade in the systematic biopsy group, there was a higher percentage as compared to the MRI group. And very similarly, 35% of the systematic biopsy group had a failure of active surveillance as 2 years compared to the MRI. So the take-home message, please read the red ink lines. The initial MRI and targeted biopsy did select more significant cancer, so there was a very significant reduction in the 2-year biopsy rate in the MRI arm. This would be my personal consideration in my practice. When a patient comes in with the diagnosis of a grade of Gleason group 1 prostate cancer, so Gleason 3 plus 6. He's a candidate for active surveillance. What I would always recommend, the biopsy slides should always be reviewed by an expert GU pathologist. When done at my center, the diagnosis is eventually changed in more than 40% of the cases. If the MRI has been done already, I always request my GU radiologist to review those films, because if they find any pirates 4 or 5, then I would recommend the patient to have a second set of biopsies, which clearly would be MRI targeted. If the MRI was not done before the biopsies, and this is something that unfortunately I still see quite often, at least in my country, then I would recommend the patient to have an MRI for the first time, clearly, at least 4 months after the biopsies. By doing so, you will be able to really identify who is the best candidate for active surveillance. The third topic that I would like to cover is the recurrence after curative intent treatment. These are the indications from the very latest edition of the guidelines about local salvage treatment. So we are talking about biochemical recurrence after radical prostatectomy, offering only prostate PSA monitoring with patients who have a biochemical recurrence but a low risk feature at relapse. This is something that we should consider. We do not need necessarily to treat everybody who is showing a biochemical recurrence. Salvage radiation therapy is a good way to go. Whenever you have taken the decision to use salvage radiation therapy, which should be given with at least 66 grays, it should be given as soon as possible. A topic which is open to discussion is offering or not offering hormonal therapy in addition to the salvage radiation therapy. So this is the research in context. There are 2 studies. The study done in France, which did compare androgen deprivation therapy plus radiation therapy versus radiation therapy alone in patients with a rising PSA after radical prostatectomy. And there was an improvement in the results with the combination of hormones plus radiation therapy, and the well-known to all of you RTOG study published in the New England Journal of Medicine, which compare radiation therapy plus or without bicalutamide and placebo, and also gave a suggestion that bicalutamide was useful. This is the trial that I have identified for you. This was an open-label, multi-center trial with more than 700 patients. The patients did receive radical prostatectomy, and their PSA went down to 0.1 and remained stable for at least 6 months. So this was a patient population with a 0 PSA at the end of those 6 months. Then they did receive radical radiation therapy alone or radiation therapy plus 6 months of ADT. The median dose was 66 grade, and the progression-free survival 10 years down the line was 64% with the combination therapy compared to 49% with radiation therapy alone. This was highly significant. And the metastasis-free survival did remain significant as well down the line. When looking at the various possible predicting factors, taken one by one, there was none of these which was statistically significant, but taken all together, there was a statistically significant difference. But clearly, when looking more in detail to the results, it became evident that those who did have bad disease to start with, like Gleason score greater than 8, did represent patients who would have the best benefit by the addition of hormones to radiation therapy. And this is what we found in 2 studies produced at our own institution when looking at this very question. Should the salvage radiation therapy be associated with androgen deprivation therapy? And if so, for how long? We found out in these 2 beautiful studies that only patients with more aggressive disease characteristics benefit from androgen deprivation therapy, and typically at our own place, they should have at least 2 of these 3 parameters: PT3B disease, Gleason 8 to 10, a PSA at the start of salvage radiation therapy greater than 0.5. These are the patients who would benefit at our own place with the addition of hormonal therapy. If you give hormonal therapy in these patient subsets, it should be given for more than a year. Lastly, management of metastatic hormone-sensitive disease, a very cool area, a lot of new papers coming out over the last 6 months or so. We now know, according to guidelines, that in a patient like this one, we should not only use androgen deprivation therapy, but also add docetaxel, and the same goes for abiraterone acetate plus prednisone. Clearly, this is what has been shown by papers. It has been accepted by regulatory agencies. It is another story to look at different countries in terms of reimbursement, because as we all know, the new drugs, the new pills are very costly, and so it is not always easy to have them available. This is what the guidelines are saying today. Use a combination of ADT with docetaxel, use a combination of ADT with abiraterone plus prednisone. These are strong recommendations. Starting from this point, first paper that I have selected, the enzalutamide in this area. So these were patients with prostatic cancer and metastases found with the old ways of looking at our patients. CT, bone scan with technetium, or both. Please consider this. This is not what we would probably do today. So in an open label fashion, these patients would use typically either androgen deprivation therapy or added with a standard non-steroidal anti-androgen or with enzalutamide. And the primary endpoint was overall survival. If you look at the curve here, comparing enzalutamide and standard of care, this was the median follow-up, and the number of deaths between the two groups was significantly different. And look at the red words here. The overall survival at 3 years was 80% with enzalutamide and 72% in the standard of care group. The effects of enza on PSA progression-free survival and clinical progression-free survival were larger than its effect on overall survival. And there was a smaller effect of enzalutamide in patients with high volume disease. So good news, but clearly we have to look also at the adverse effects point of view. So the seizures were more frequently present in patients in the enza group. This is the classic adverse event of enzalutamide, which is by far well tolerated, but still we should record this. And also clinically significant fatigue was recorded more frequently with enza, and although altogether it was very nicely tolerated. So the take-home messages with this study: in men with M+ hormone-sensitive prostate cancer who are already under ADT, if you add enza, you should expect a longer overall survival, PSA progression-free survival, and clinical progression-free survival within 3 years. And you should always remember and discuss this with the patient that some additional toxic effects might come out, including fatigue and a small risk of seizures. Apalutamide is another drug which has been under evaluation for quite a while. It has been already approved in other settings. So apalutamide was also studied and reported in patients with metastatic castration-sensitive prostate cancer who did receive apalutamide or placebo added to ADT. Clearly, they should have a documented adenocarcinoma of the prostate M+. And the study did look at the radiographic progression-free survival and overall survival. Again, a very large number of patients included in this trial. 16% of these patients had undergone either prostatectomy or radiation therapy, and some of them had already received docetaxel. The median follow-up was 22 months. Radiographic progression-free survival at 24 months, so 2 years down the line, was clearly better in the apalutamide group as compared to the placebo group, and this was consistently in favor of apalutamide, also regardless of the subgroups that were analyzed, including previous docetaxel use and both high and low disease volume. When looking at the overall survival, a difference was still there. It was clearly, and as expected, less evident, but still it was there. 82% for apalutamide, 73% in the placebo group. There was no significant difference in the effect of apalutamide according to disease volume, and this is good news to hear. What about the side effects? Of interest, there was not a significant difference between the two groups. So it looks like apalutamide is indeed extremely well tolerated, and if a patient is already using ADT and he is then using also apalutamide, he is probably not going to report to you very much issues. The take-home message here from this study, apalutamide plus ADT resulted in a significantly longer overall survival and radiographic progression-free survival than placebo plus ADT only, and the safety profile did not differ notably between the two groups. And this is actually what the guidelines are saying today. Offer ADT combined with either abiraterone plus prednisone or apalutamide or enzalutamide to these patients. As I was alluding to start with, clearly the issue of reimbursement is going to be important. And if you go back to the issue of the New England Journal of Medicine with these papers, there is a very interesting editorial by Professor Tannock from Canada. And so the question, he says, would remain, which drug should we use? And the answer depends on price. And I think it makes very much sense. The major determinant of access to treatment, and this is favoring abiraterone. Why is this? Because abiraterone is already generically available as a generic drug in the US, and it costs not so much. So that is going to play a key role, I think, also in Europe in the future. Please do remember to complete your questionnaire if you want to receive not only the certificate of attendance, but also the credits, which is important. It is now time for questions, and I think that Marcus has collected a few of them, and I will be happy to take them as much as I can. Thank you very much for your attention.
Okay, thank you very much, Francesco. That was a very nice overview over the literature in the last year. And indeed, we got a couple of questions, and I'm going to start. First is, what about the biparametric MRI? The majority of these studies are multi-parametric. What is your opinion on that? Can we replace it?
I think, excellent question. I think that that is very much depending on the technology which is available at that specific center and at the ability of the GU radiologist. I was very much impressed, Marcus, by seeing the new technology at our center with the 3 Tesla with an endorectal coil. Although I am not an expert in MRI of the prostate, I can tell you that also from my perspective, I can say that the vision is better and one is seeing better the lesion there. So it is possible that if you start from that side, using a very good technology, also biparametric can be advantageous. Clearly, it would be very important in terms of reducing the cost and reducing the time of the examination. And we know that there are a number of patients who don't like to remain into the MRI machine for 40 minutes or so. So I hope that it will become of normal use.
Okay, very good. One question was what is your preference, like an automatic biopsy, fusion biopsy, or is a cognitive biopsy as fusion biopsy enough? Is it
very good question, Marcos. I think that at our center, at least, we have transitioned completely to the software-guided type of biopsies. although we have excellent urologists who are able to perform a beautifully done biopsy also with the cognitive approach. But now in our suites for the biopsies, the technology is available, so we always do the thing like that. What are you guys doing in Hamburg?
We're actually doing the fusion biopsy with the machine, but there have been studies showing that there's obviously not a big difference if there's an experienced investigator doing the cognitive biopsies, but we are doing routinely the machine-based biopsy.
Are you now using in Hamburg also the bioparametric approach when doing the MRI, or still the old way?
I must say that we have discussed it with our uroradiologist, but we couldn't convince him so far. But
Okay.
we're actually thinking that it makes sense in order to give a better, providing more MRIs. I think it's important to increase in general the quality of diagnosis, and I think it's better to have more biparametric MRIs than a restricted number of multi-parametric MRIs. And the other thing is reimbursement. You mentioned that as well. So affording a biparametric MRI for someone who's not a private patient is easier than a multi-parametric MRI. So I think I'm a big fan of biparametric MRI, but yeah, there are other players in the field as well.
A question that I have for you, in a country like Germany, is the issue of the quality of the multi-parametric MRI still an important one? What I mean is, you see many patients who come in to ask for your guidance were having their own MRI done. So you look at that. How often do you think that the quality of the test is not good enough?
I cannot give you a number, frankly, but we certainly see the same as you probably see in Italy as well and in other countries, that there's in many situations a lack of quality. So the quality criteria, for example, in the German guidelines are defined, but not everyone is sticking to that. But in the vast majority of MRIs we're seeing now are of sufficient quality, I may say that.
Well, I think that an important message for those who are listening to us is to always double check the quality of the MRIs. Because whenever you consider the MRI which is shown to you by the patient as a good one, you are taking a huge responsibility. So you really want to know, to be sure that the quality of the MRI is good, because you are going to make your decisions about the results of that specific MRI. So I agree with Marcus. Overall, the quality is improving. What I would do at all times, I download the images of the MRIs in my computer, and I would show it to our radiologist next day, just to be sure. And if the quality is not good enough, I would certainly tell the patient, my recommendation would be to have this test a second time, and I would do all I can to explain to them the importance of the good technique.
Okay. Very good. Another short question. What are you doing with patients on active surveillance who are BRCA carriers?
Now, this is a good one. Now, the first thing, the use of genetic testing in the area of active surveillance is very slowly picking up in my country. I would say that only major academic centers are using this as a routine. There are two different issues there. Number one is the cost. These tests remain quite expensive. Number two is the time to have the information about this specific testing, which indeed takes a little bit too much in my opinion. And number three, another problem that we are facing in my country at least, is that there are not so many experts who are able to give a very good counseling in terms of genetic testing. To go back to the question, if the patient is a BRCA2 carrier, then clearly we should explain to him that he has a risk of developing a worse disease as compared to the starting point. Clearly, it goes down to the age of the patient, comorbidities, but indeed, it is something that we have been considering more and more. What are you guys doing? Is now genetic testing very much used at Martini Clinic?
It's used, but we try to identify those patients that are at risk. We have a good cooperation with our gynecologists, especially of those patients there who are BRCA mutation carriers. If they have a brother, for example, then we're thinking about informing these patients. But it's difficult, as you said. So what is the consequence? Someone has a mutation carrier. What is the consequence of that? For example, in active surveillance, we're not routinely using that because the likelihood that you find someone is A, very low, and B, what are you doing? You're watching more carefully maybe, but that's it at the end of the day. So we offer that, but only in patients who are at risk for a family cancer history.
Well, I would say, Marcus, I agree. The only area where sequencing of these patients has become a routine are patients with metastatic disease. And we have learned to do this by our medical oncologist colleagues, also in other areas. So typically, there are two of us who have become quite good experts in the area, so that whenever we have a patient where we believe that genetic testing would be useful, then they are followed using a specific program and they receive this type of testing, and then we decide what to do together with the medical oncologists who are still in Italy running the show because they are able to make the prescription. I know it is different in Germany, but in our place, I cannot prescribe abiraterone or enzalutamide myself, for example, but it has to go through the medical oncologist.
Okay, so I have so many more questions, but I think we have to finish at this moment in time, and we're going to start with the second part of the presentation.
Excellent.
So as Francesco mentioned before, usually when we give the course, it's a 3-hour course. Now we've condensed it down to 1 hour, and we are going through the whole spectrum of prostate cancer, starting from the beginning, then to the very advanced disease. Now we have to jump a little bit back and forth. I'm sorry for that, but I've got certain subjects I want to tell you. Just a second. Okay. So I have no conflicts of interest. And the first subject I want to talk about is the new literature on screening and novel biomarkers. So we go very much to the beginning of prostate cancer, like what is new in with respect to screening in 2019, 2020. I think the most important study that was published in the last year is the 16-year follow-up of the ERSPC trial. You know that trial, 160,000 patients were randomized in 8 European countries, and there have been lots of publications before. Some of the publications used the data from all 8 centers in Europe. The last one was published in 2014, and what was seen is that the incidence of prostate cancer was certainly raised when you use a PSA screening by 1.6, which is clear. The more you search, the more you will detect, and as well that the relative risk reduction of mortality was about 21%. And that is about 6 years ago that all these 8 centers put the data together and that was published. And now the authors felt that it was time for an update. And 2 questions were asked. First of all, is there now a bigger difference in mortality reduction with this additional time of follow-up? And the second question, which I think is very interesting, does it make a difference if you detect a cancer in the first screening round or in the second screening round, in the later screening round? And you have to keep in mind that for these patients, for patients who are detected in the first round, you catch a lot of the prevalence of the disease, and this is not actually the idea of a screening test to get the prevalence. So it's more important certainly to see what happens in the second round when the first PSA was negative, but with time the PSA is elevated. And the data for that are just coming. You see when you look at the 16-year follow-up of the whole cohort, then you see that the mortality was pretty much the same like in the previous publication. It was about 20% relative risk reduction. In absolute numbers, it was not that much, but you have to think that not a lot of patients or men at all develop prostate cancer in that cohort. And the other thing is that the time from diagnosis was 8 years in the screening group and 5 years in the control group. So it's not a long follow-up really for those who develop a cancer. So no change in that with time. And that is a big issue here. You see that those men who attended just 1 screening round, that means 1 PSA check during the whole study period, in those 16 years, 1 PSA check, the mortality reduction was just 25%. I think that's quite a lot, but it's more emphasized if patients had, or men had a negative PSA at the beginning, but then developed to suspicious PSA and then underwent diagnosis. And in those men, the mortality reduction was 48%. So it looks that it makes sense not just to do one test, but to follow the patients. And I think that is exactly what a screening test should do, certainly informing the patient about all the consequences a positive test can have and the potential side effects of treatment and so forth. I think that was a very important point, that we know now that continuous PSA measurements increase the effectiveness of screening. And there was a brief correspondence with respect to exactly that paper that I mentioned to you, and it discussed the drawbacks of the ERSPC study. As I said, it's 8 countries, and there was a lot of variety of how people did the screening. So study attendance, for example, was only 30% in France, only 30% went really for the PSA checks, or biopsy compliance. In Italy, it was just 40%, whereas in Finland, 91%. Screening intervals, 2, 4, 6 years, that made a difference. And certainly what treatments are given made a difference as well. So the mortality reduction rate varied quite a lot, and was brought down to 0.63%, 0.63 in Sweden, whereas, for example, in Italy, there was virtually no change in the control or the screening group. So this is a nice graph showing that, and you see the base model. This is 1. This means that screening has no effect, and the more it goes to the left side, the more effective is the screening. This is the mortality reduction, 10%, 20%, 30%. This is the base model for all the patients. And for example, when we look at screening intervals, you see that at 2 years you have a higher reduction of mortality when you compare that to 4 years of intervals or 6 years. So this all definitely impacts how cancers are detected, at what point in time are they detected, and how much is the mortality risk reduction. I think a very interesting study that gives you more insight into how a screening program should be run. The other issue I looked at was biomarkers, and I would say it's a bit disappointing that we have so many potential biomarkers on the horizon, but there's nothing really in the routine, at least not in Germany, I may say, probably not in Europe. It's more used in the United States. And this is a statement paper published in JCO last year, where they put together an expert panel and looked at all the literature that is published. And the question they had was, do we have molecular markers based on the tissue that can help us do our clinical guidance? And they looked at various clinical scenarios, for example, support of active surveillance, or in patients who underwent radical prostatectomy, do they benefit from adjuvant radiation therapy, and so forth. And finally, they ended up, after a really rigorous literature search, only with 5 tests that are commercially available and that were tested in a good way, or in a sufficient way. And you see all the available tests here. As I expect, not that many people in Europe will use these tests, Polaris, Decipher, and so forth. And the statement of the colleagues from the United States was the following, that multiple biomarkers are available. They are helpful in refining to the characterization of a cancer and to add value to risk estimations. However, and I think that's a very important message as well, we do not yet know whether this better knowledge about the cancer will lead to changes in management, and if these changes in management really change outcome with respect to quality of life or effectiveness of the treatment. So they said biomarkers can be considered in selected men. Ask the patient or ask yourself or together whether this really changes the management if you order one of these tests that cost between $4,000 and $5,000, by the way. And the final statement, most important, is the routine testing for patients with localized prostate cancer was not recommended. I think a very clear statement in 2020. Second subject I looked at was about staging. And as you can imagine, the literature here was ruled completely by PSMA PET-CT scanning. And the most important study you should definitely read is the PRO-PSMA test trial that was just recently published. It's a prospective randomized trial, and we know all that in patients with high-risk disease, if we perform our conventional CT scan and bone scan, that we lack quite some of the metastases. And the question here was whether giving upfront a PSMA PET-CT scan instead of the conventional imaging, will that lead to a higher staging accuracy? And second point, change to management of prostate cancer patients. So this was a study that was performed in 10 Australian centers. It was a multi-center arm, two-arm randomized trial, 300 patients. And the design was interesting in the way that all the patients received all the imaging tests. So group 1 was randomized into upfront conventional CT and bone scan, and then get in between the next 3 weeks a PET-CT scan. And the second group get the PET-CT scan upfront, and then received in between 3 weeks the conventional imaging. As I said, inclusion criteria, high-risk patients, according to the NICO criteria that you will know. And only when there were lots of metastases seen, there was no crossover, but otherwise all the patients crossed over. And then, which was very interesting as well, how can you evaluate when you see a lesion that it's really metastases? They made something like a composite reference endpoint. That means either histological validation of that lesion by a biopsy or lymph node dissection, for example, or the respondents to treatment and so forth. So they had lots of criteria suggesting that a lesion indeed is a metastases. And the results for that comparison of the new and the conventional imaging is the following. We found a 92% accuracy for PSMA PET-CT scan and only 65% for the CT and bone scan. So offering a clear superiority in accuracy for the upfront PSMA PET-CT scan. And the other important issue was the management impact that the second imaging had. And they did a questionnaire after the diagnosis, judged together with the practitioner, judged or decided what treatment he probably will offer to the patient or suggest to the patient. And then you get the first line imaging, was asked again, and then you get the second line imaging and was asked again to see whether there's a management change. And with the CT and bone scan, it was in 50% the case that the management was changed compared to 28% after the PSMA PET-CT. Equivocal unclear findings, as you would expect, more often 23% in bone scan, 7% in PSMA PET-CT. And very interesting finding as well as radiation exposure, it was lower in the PSMA PET-CT scan. We don't have information on cost so far, but that is another issue that will be investigated. But the conclusion of this study is that PSMA PET-CT, where available, can be a suitable replacement for conventional imaging. And I must say that I completely agree with this statement. Certainly, as it is mentioned, availability is a problem. In Germany, it's not a problem really, but certainly cost issues are important. As I said before, there will be cost analyses, and the judgment is out whether it might even be more cost effective if you have a good scanning at the beginning rather than a mediocre scanning with all the questions that rise afterwards. Certainly, we still don't know, and this will be done in the follow-up of this study, whether this management change leads to better outcomes. We have to see that. Another imaging study was looking at those patients who were candidates at the SPA trials. We know already these trials, we discussed them years ago. It's the SPART and the Prostate and the Aramis trial in non-metastatic castration-resistant disease, and you probably have seen on the meetings that was discussed whether this is something like a made-up entity, because everyone knows that a patient with castration resistance and a rising PSA, they must have metastases, but the conventional imaging, which was used in these SPA trials, did not just detect them. So in this study that was led from a German group, they looked at those patients who fulfilled the criteria of the SPA trials, and then looked in their PSMA imaging whether they see a metastases or not. So all these patients had non-metastatic castration-resistant disease according to conventional imaging and inclusion criteria of the trials: PSA above 2, high risk for metastatic disease, which is a doubling time below 10 months, and or Gleason 8. And the interesting finding is that 196 of 200 patients, there was a lesion found. 44% had pelvic disease, 24% had local recurrence, by definition not metastatic, because they were pelvic, but more than half of the patients who were negative on conventional imaging had M1AB or C disease, and the interobserver group was very high. And the risk factors for finding a M1 disease, everyone had lesions, as you've seen before, but lesions outside the pelvis. The risk factors for that was a high PSA, nodal involvement in primary pathology, and whether radiation therapy was given or not. So this is a graph for that. You can see here, this is per definition not metastatic, but lesions seen on the on the PSMA PET. And these are the 55% where you see extrapelvic lymph nodes, bone metastases, visceral metastases, as said before, all negative on conventional imaging. So the take-home message here is almost every patient, as we would have expected, but now it's shown, have lesions that are visible if you have a sensitive enough imaging, and half of the patients have M1AB or C disease. Next question certainly is how to deal with that. I'm sure you will ask that question, whether we should do metastasis-directed therapy or not, but that is body of new research. Okay, let's go away from staging and imaging to local treatment. And so I overlooked radiation therapy and surgery and brachytherapy and active surveillance. And I think one of the important studies that was published in this area this year was the comparison of quality of life issues. You may say this is not the newest idea. There have been so many other publications on that. For example, the Prostate trial in the UK, they looked at quality of life issues as well. But the authors thought that it's time to make an update in their current database. It's a SEER database-based study because of refinements of treatment, like robotic radical prostatectomy might improve functional outcome compared to Prostate T that was all open surgeries, or refinements in radiation therapy like image guidance and so forth might lead to better functional outcomes. So they looked at this database and compared 5 years after treatment what the quality of life impact of that respective treatment was. The other important issue why they did this study is that it was stated that certainly patients with favorable risk disease need less intensive treatment, means potentially less side effects, for example, nerve sparing, whereas patients with unfavorable risk of prostate cancer, they usually end up with either surgery non-nerve sparing or radiation plus androgen deprivation therapy, which is not given in favorable risk disease. So they separated this database into favorable and unfavorable risk disease and looked at the impact of quality of life. There have been, as you can imagine, a couple of graphs in that study. I just want to focus on two. You see here, favorable risk disease, the impact of the various treatments. This is a time frame, 3 years, 5 years. You see this is the baseline. This is radical prostatectomy, the red line here. The impact on sexual function was certainly very high in the first months, but then recovered by 5 years. The radiation therapy treated patients started up at a lower level and did never really recover, just gradually went down. Active surveillance the same, brachytherapy, just some meditation at the beginning. At the end of the day, I must say that the impact on sexual function after 5 years was pretty much the same, regardless of what was given. However, in favorable risk disease, urinary incontinence, radical prostatectomy, as shown in the Prostate T trial, was worse with respect. All the other domains of quality of life were pretty much the same, but urinary incontinence was lower, and I think that's important information for counseling about patients. So take-home message of that study, most function differences attenuated by 5 years. As I said before, incontinence in favorable risk disease was the worst after radical prostatectomy. And for the non-favorable risk category, where radical prostatectomy was compared with radiation plus hormones, one important issue that sexual function actually was better after radiation therapy than after radical prostatectomy. I thought it was pretty bad in both situations, which is the case, but even worse after radical prostatectomy. Again, an important information we need to know because we don't have randomized trials so far on high-risk disease. What is the best local treatment? And this is another study that tried to answer this question. What is the best local treatment in high-risk disease? Published in 2019 in European Urology, looking at the National Cancer Database. So the reason why the colleagues did that study was that they said, yeah, there's not a lot of good literature. Randomized trial is still awaiting. The SBCG15 is running in Scandinavia. What shall we offer patients? And very often you see certainly selection bias. With older, more morbid patients receive radiation therapy. The fitter, younger patients radical prostatectomy. So they limited their study to patients who were 65 or younger, so young patients, and all had virtually no comorbidity, so chance of comorbidity of 0. Healthy young patients with aggressive disease, what is the best local treatment for those guys? And what they found here, you see the inclusion criteria that you all know, high-risk disease, is that in fact the efficacy of radical prostatectomy was higher than compared to radiation and brachytherapy in combination. So this is one of the many studies that is published. We had studies showing an advantage for the combination of external beam radiation and brachytherapy. This is a study, really big, 14,000 patients, long-term follow-up, that showed a slight advantage for radical prostatectomy in this young and healthy patients. Again, I think very important information. There are limitations, we don't have to discuss that, but another piece of the puzzle about the information of how to treat patients with high-risk disease. One nice study I've chosen because I like that study because it asks a clear simple clinical question and a simple clinical answer. In patients where you think about combining radiation with hormones, shall you start the hormones in advance, like neoadjuvant approach, or shall you give the hormones concomitant with the radiation therapy? Does that make a difference? And the group that was looked at here was intermediate risk disease patients with some high risk features. Not only high risk, they should give the hormone therapy longer, but here it was investigated for 6 months, the additional hormonal therapy, and either started 4 months prior to radiation therapy or with the radiation therapy. You see the patient characteristics and the endpoints. And the result is very clear. It doesn't make a difference. This is biochemical recurrence-free survival, no significant difference. This is 10-year overall survival, so 1 follow-up, no difference. And this is toxicity, greater than 3 grade toxicity was low in those groups and equal in both groups. So the take-home message from this study is, if a patient is asking you, shall I start before or with the radiation therapy in this risk category, it doesn't matter. It matters that you give hormone therapy in addition, but it doesn't matter when you do that. So my final subject is management of castration-resistant prostate cancer. I think the most important study that was published last year was the CART trial. The CART trial asked the question, how shall we treat patients that progressed after docetaxel and androgen inhibiting drug? And they had a randomized trial with 255 patients with metastatic castration-resistant disease who had docetaxel and ARBI or ANSWER. The inclusion criteria was 12 months progression or after in the 12 months after they received the previous drugs. So these are the inclusion criteria, as I said before, and then the patients were randomized. They received either cabazitaxel plus granulocyte colony-stimulating factor to reduce the side effects, neutropenia, and the other arm received either ARBI when they had ANSWER before or ANSWER when they had ARBI before. And these were the endpoints. It's imaging-based or radiographic-based progression-free survival. That was the primary endpoint, but secondary key endpoint was overall survival as well. And to make the long story short, it was a clear advantage for cabazitaxel and this group of patients, third-line therapy. I like this graph very much, which I copied from the New England Journal. You see 129 versus 126 patients, and this is the median progression-free survival 8 months after cabazitaxel and 3.7 months after change to one of the androgen inhibitors. The thing that you might think about, which I was a bit surprised at, that serious adverse events were the same in both groups. Actually, the medication was stopped more frequently in this group mainly because of progression. So you don't buy this with a higher side effect profile. The side effects are there certainly, but pretty much well controlled. But the efficacy of cabazitaxel was clear. So again, these are the Kaplan-Meier curves for progression-free survival. This is overall survival. And the take-home message from this study is improved imaging-based progression-free survival with cabazitaxel at third line after androgen signaling inhibitors and docetaxel, clear result. Overall survival as a secondary key endpoint was positive as well for cabazitaxel. And the author state that it should be considered as the new third-line therapy in metastatic castration-resistant prostate cancer. So finally, to see how dynamic the field is, we have this statement here, and not yet published, but just giving you something like an outlook on the last ASCO meeting. Pretty much the same patients were considered from a group from Australia. Ian Davis and Michael Hoffman did the so-called therapy trial. It's a randomized phase 2 trial. And as I said, they looked at those patients as well, as we saw in the CARD trial, who had docetaxel and AVI or ENSA, and then randomized them into cabazitaxel, which was the winner of the CARD trial, or 177 lutetium. And they showed primary endpoint was PSA decrease, not the hardest endpoint certainly, but it showed a clear advantage for lutetium, 67% reduction and versus 37%. Progression-free survival was in favor to lutetium. Certainly, we have to be aware that this was done in lutetium positive or in PSMA positive patients. Those who were PSMA negative with castration-resistant disease were excluded from the trial, which the author thought was an advantage to more individualized treatment. So we see we have the new standard, third-line standard is now cabazitaxel. We certainly have to wait the full publication of the therapy study, but yeah, it's all work in progress. And yeah, I'm happy to take questions. Thank you so much.
Excellent. Marcos, I think you gave a wonderful talk.
Thank you.
And we do have a number of questions in the last few minutes that we have available. So a lot goes with the PSMA PET. And the first question would be, in case of a biochemical recurrence after radical therapy, how would you use PSMA PET and multi-parametric MRI before taking your decision about what to do?
Yeah, very good question. I would do a PSMA PET CT scan. There have been studies on MRI as well, but I'm completely convinced about PSMA PET CT because I think the sensitivity of that is better. And we, as a routine check now, recommend every patient with biochemical recurrence to undergo PSMA PET before we start to do the counseling. And whatever we see there will lead our management.
And would there be a limit of the PSA? What I mean is, do you wait until a PSA of 0.2, or also if it would be less?
Actually, we use 0.1. I know that there's a big discussion behind that, but it depends as well, as we discussed before, on the quality of the PSMA PET and how dedicated the nuclear medicine guy is. If they wait a little bit longer and the washout phases and so forth. So as I'm playing around with the imaging as well is very important. So we start at 0.1, and in about, I would say, 10 to 20%, we see in the range between 0.1 and 0.2 positive lesions. And certainly those patients are then the best candidates, for example, thinking about a metastasis-directed therapy. So Tobias Maurer from our group and others have shown that if you do a metastasis-directed therapy, the lower the PSA is, the less lesions there are, the better is the efficacy of this experimental therapy. So I'm in that of low PSA.
And Marcos, now with the availability of PSMA PET, etc., if you see a patient with a biochemical recurrence and the PSMA thing is completely normal, would you proceed? Let's imagine that this happens 4 years down the line after a radical prostatectomy. So you are suspecting a local recurrence. Mm-hmm. Would you then do, like we did in the past, radiation therapy on the prostatic fossa, or because the PSMA thing is normal, you would tell your patient just wait?
Again, very good question and clinically relevant, because that is what the patients are asking. And I prepare the patients before. I say there's a substantial likelihood that we will see nothing, but that is good information as well. For example, as you mentioned, a patient 3 years after radical prostatectomy, having a biochemical recurrence 0.3, PSMA PET is negative. So I tell the patient, if you have to think about before if you want to have local treatment, if that's sufficient or not, looking at age and so forth. But if you think you're a good candidate and we see nothing in the PSMA PET, that is good news because it's not spread. And then we make your salvage radiotherapy field according to the pathology. If we see something, good news as well, because then we can change our management according to the lesion we've seen. So I think a negative PSMA PET in that direction is an important information, one thing. And the second thing is, yes, I would, if the patient is a candidate for a salvage radiation, I would then do the salvage radiation like we did in the years before. And then I say, at least in German guidelines, the situation is clearly discussed and suggested as I've just stated.
And let's play the game, but in the scenario of being prior to the operation. So what would be the classic candidate for you in Hamburg, where you want to have a PSMA PET at all cost before the radical prostatectomy?
So the ideal candidate would be everyone, but certainly not everyone can afford that. I'm curious how the guidelines will react according to the pro-PSMA data, and I think the cost-effectiveness outcome of that study is very important as well. But from my side, I would suggest every patient who can afford that a PSMA PET CT scan. That is my personal opinion. This is not according to the current guidelines, but I think the information is so important that we get out of this better staging tool that we should use it as long as we can afford it.
I presume that if you were obliged to make a selection because of cost issues, you would first probably consider patients at high risk.
Absolutely. That's what I thought you mentioned. I'm talking about high-risk patients, and certainly I think that's important to make that point, because the likelihood of metastases in the other risk categories is so low that I'm not suggesting PSMA PET in that situation because of the very high likelihood of that it's negative.
We have recently started to use PET combined with MRI as contrary to CT. And although the initial experience is limited, it looks like for whatever reason, the combination of PET plus MRI, and this clearly goes with PSMA as a tracer, is having a better specificity as compared to PET CT. Do you also have an experience with the PET MRI in Hamburg?
Not systematically. So we have some outside PET MRIs that are coming in, but I cannot support your statement. I assume that it's the better background imaging with the MRI, but I have no personal experience with that.
It's interesting. I think that time will tell. I am afraid we are running out of time, but I think that we can take the very last question, which is again very practical. What would be the indication today at Martini Clinic to consider a radical prostatectomy in the patient with oligometastatic disease?
Yeah, we ran the RAMP trial that was closed after we saw the STAMPEDE results. So we stick according to the inclusion criteria of STAMPEDE. So we tell the patient if he has oligometastatic disease with up to 3 bone metastases on conventional imaging, that radiation therapy, in addition to all the drugs you've mentioned, is the standard, that radical prostatectomy is experimental, yet we have published a comparison between radical prostatectomy and radiation therapy, that it is an option, and we stick to the inclusion criteria of STAMPEDE trial. But we are now outside of the trial offering radical prostatectomy in oligometastatic disease.
And we would do the same. So another very practical question, and I promise this is the final one. In that patient, if he has not started any type of medication yet, would you like to have him on hormones to start with and then reconsider radical prostatectomy, or would you start with surgery and start the hormones at the same time or later on?
I would say it's not such a big issue. It certainly depends on the local situation. If those patients, which is often the case, have a locally advanced disease, we rather like to kind of downsize them with 3 months of hormonal therapy, maybe even with, for example, apalutamide, if they have bone metastases, like a second drug as well, and then see whether they are good candidates for radical prostatectomy. If not, then if it's still locally advanced and we're a bit afraid of the potential side effects of radical, we certainly suggest them to undergo radiation therapy. So local therapy, I think, is important in those patients, and then you have to look on how good is potentially the surgery, if it's possible or not. But yeah, if the patient has no hormonal therapy and it's rectal disease, I think you can start with a radical prostatectomy, and then once he's home, start with the hormones. I think there's no clear data on that you can make a clear judgment.
I think that in Milano, Marcos, we are doing quite the same. A lesson that I have learned myself is that when dealing with oligometastatic patients, we should not overpromise, because we all know that there are cases where you do a procedure that from the surgical perspective you consider, I did it really well. Then the patient comes back and the PSA, the first one after the operation, is really disappointing. So certainly it is an area where it is at least gray, I would say. So more research is needed. I think it was wonderful. Would you like to take a few minutes just to say hello to everybody and to finish the session, Marcos?
Yes, I enjoyed very much to give this course together with you. I think it's the 3rd time we did that together. I learned a lot, I must say. It's always interesting, your vision on the view on all these studies you've mentioned. I just would like our listeners to fill in the questionnaires, because otherwise you don't get a CME accreditation. And the other thing is, I would certainly suggest to you all that you follow the other webinar courses. You will get an invitation email in the next days where other courses like this one is suggested. I think it's an excellent initiative from the EAU. I enjoyed very much to have not a lot of traveling with all these talks, and yeah, I enjoyed it, and I hope you enjoyed it as well and learned a lot. I did that. Thank you so much. Have a nice evening all together.
Well, thank you also. All the very best to all of you, but don't forget that in 2021, the meeting will be in Milano. So you must be there. All the very best.
Okay, thank you. Bye-bye.
Thank you.